Ever wonder how doctors figure out exactly what's going on inside your lungs without ever turning on an X-ray machine or an MRI? It honestly seems a bit like magic, right? But it's actually this incredibly precise, time-tested clinical science. Welcome to today's Explainer.
Today, we're diving straight into the exact clinical methodology doctors use to solve the mysteries of your respiratory health. Think about it. Long before advanced imaging even existed, physicians mapped out a remarkably accurate system using nothing but their eyes, their hands, and a stethoscope. They can detect fluids, pinpoint solid masses, and identify collapsed airways literally just by tapping and listening.
To do this, medical professionals follow a strict roadmap known by the acronym IPPA, which stands for Inspect, Palpate, Percuss, and Auscultate. Today, we're breaking that down into 5 clear steps: mapping the human chest, visual inspection of breathing, palpation, percussion, and finally, auscultation. Let's walk right through this exact structure. Kicking things off with Step 1, mapping the human chest, or setting up the invisible coordinates.
So before a doctor even touches a patient, they basically have to mentally divide the human chest into a grid. They need to know exactly where underlying structures are located. For instance, our lungs actually aren't perfectly symmetrical. The right lung has 3 distinct lobes, upper, middle, and lower. But the left lung, it only has 2. Why? Well, because it essentially sacrifices a lobe to make room for your heart. Understanding this asymmetrical layout is absolutely crucial, because a disease might be isolated to just one specific lobe.
To accurately document exactly where a problem is, doctors use invisible vertical reference lines. You've got the mid-sternal line running right down the dead center of your chest, the mid-clavicular lines dropping straight down from the middle of your collarbones, and the axillary lines mapping out your sides near the armpits. It's basically a GPS coordinate system for the thorax, allowing doctors to precisely track and locate physical findings.
Moving right along to Step 2, visual inspection. This is really the art of observation. This inspection actually happens the very moment the doctor walks into the room. Before a single word is spoken, they're watching the patient breathe, immediately looking for structural abnormalities that might restrict lung movement. For instance, a barrel chest, where the front-to-back diameter is unusually wide, is a massive clue, often associated with chronic obstructive emphysema. There's also the pigeon chest, where the sternum projects forward, or the funnel chest, where it's depressed inwards. Even spinal curvatures like kyphosis or scoliosis can severely compress the lungs and restrict breathing.
After taking in the overall shape of the chest, they count 16 to 20. That is the number of times a normal, healthy adult breathes per minute. Establishing this baseline is totally vital before we start looking for abnormal, dangerous rhythms. And having that baseline really helps us recognize those abnormal rhythms. Notice how specific breathing patterns directly point to severe underlying conditions. Take cusmal respiration. It's this deep, rapid air hunger seen in patients with severe metabolic acidosis, like diabetic ketoacidosis. Then you have Cheyne-Stokes, which is a highly irregular pattern where breathing progressively deepens, then just stops entirely for a short period. That's often a really grave sign pointing to heart failure or a brain tumor. Even simple tachypnea, which is just faster, shallower breathing, is a classic warning sign of pneumonia.
Okay, let's jump to Step 3, palpation, literally feeling for clues.
This is where observation meets touch. Doctors use their hands to literally feel the mechanics of your respiratory system at work. One of the most vital things they feel for is the exact position of the trachea, your windpipe. A doctor will place their index and ring fingers on the joints of your collarbone and gently push their middle finger back into that little notch at the base of your throat. They're checking to see if your windpipe is perfectly centered. If a lung is collapsed, or if there's a massive buildup of fluid on one side, it will physically push or pull the trachea completely off-center. Crazy, right?
Another key palpation technique uses something called tactile vocal fremitus. It's a bit of a mouthful, but basically, when you speak, vibrations travel down from your voice box and resonate right through your chest wall. Doctors will place their palms firmly on your back and ask you to say words like 99 or 123. If a lung is solidified due to pneumonia, those vibrations will actually feel noticeably stronger. But if there's fluid trapping the lung, the vibrations will be muffled or even completely absent.
Next up is Step 4, percussion, or tapping the chest. Now, what's really fascinating about this phase is that it relies on the exact same physics a carpenter uses when tapping a wall to find a hidden wooden stud. You are essentially turning the chest cavity into an acoustic drum. The technique requires a ton of precision. The physician places their left middle finger firmly and flatly against the patient's chest wall, fitting it right between the ribs. Then, using the tip of their right middle finger, they strike it perpendicularly. The movement comes entirely from the wrist. Crucially, they always alternate. They're comparing the exact same spot on the left side with the exact same spot on the right side, just listening for subtle acoustic differences.
So the whole point here is how changing acoustic notes map out diseases. A healthy lung is mostly air, so it produces a nice resonant tone. But if that lung is filled with solid tissue or infection, the sound becomes dull. If there's a massive collection of fluid outside the lung, it produces a thud so flat it's called stony dullness. On the flip side, if a lung ruptures and traps excess air in the chest cavity, which is a pneumothorax, it sounds like a hollow drum. That's known as being hyperresonant.
And that brings us to our final step, Section 5, auscultation, listening to the lungs. This is easily the most iconic tool in the doctor's arsenal, the part where the stethoscope finally comes out. When listening to a healthy chest, a doctor hears what's called vesicular breathing. It sounds like the soft, low-pitched rustling of leaves in the wind. The sound of breathing in is longer than breathing out, and there's absolutely no gap between them. But if the lung tissue becomes solid, it transforms into bronchial breathing. This is a harsh, hollow sound, kind of like blowing air across the top of an empty glass bottle, where breathing out is actually longer, and there is a very distinct, silent gap between inspiration and expiration.
Doctors are also listening for adventitious or added sounds, and these are massive red flags. A wheeze, for instance, is a high-pitched whistling caused by narrowed, obstructed airways, super common in asthma. Crepitation sound like discontinuous crackling or popping. This happens when tiny air sacs filled with fluid or mucus pop open, often signaling pneumonia or heart failure. And a pleural rub? That's a harsh, grating, jerky sound caused by inflamed lung linings literally rubbing against each other with every single breath.
And this brilliantly illustrates the physics of sound, a clinical sign called whispering pectoriloquy. The doctor asks the patient to merely whisper 1, 2, 3. In a healthy, air-filled lung, a whisper sounds muffled and faint through a stethoscope. But because solid masses or fluid-filled cavities conduct sound waves so much better than empty air, that whisper travels right through the diseased tissue and hits the stethoscope loud and clear. It's almost as if the patient is speaking directly into the doctor's ear.
As clinical wisdom reminds us, examination of the chest is best accomplished when the patient is standing or comfortably seated, simply because it allows the chest to fully expand. It's truly amazing when you step back and look at the whole picture. Even in our modern era of high-resolution CT scans and digital imaging, this physical examination is incredibly elegant. By simply mapping the chest, watching it rise, feeling for vibrations, tapping for hollow sounds, and listening to the rustling of air, a trained professional can paint a highly accurate picture of your internal health.
The human body is a masterful communicator. It literally never stops broadcasting its status if you just know how to listen. So next time you take a deep breath, what invisible clues are your lungs giving away to the trained ear? Thanks for exploring the fascinating mechanics of the respiratory exam with me on today's Explainer. Keep asking questions and keep learning.